We have a very special guest today, and I wanted to spend some time introducing him. So it is my great pleasure to introduce Dr. Don Berwick. Many of you know him as the former administrator of Center for Medicare and Medicaid Services and the founding president and CEO of the Institute for Health Improvements, IHI, where he helped change how the world thinks about quality and safety in healthcare, I would say. What was always struck me about Don isn't just his leadership or policy work, but it was his clarity and courage. Don, I still remember the first time I heard you speak. It was one of the big IHI meetings. It was right after I came to you many years ago. And Don didn't just talk about healthcare as a system. He talked about people, communities, his patients, and above all, he talked about justice. And it stayed with me because you showed that healthcare is never about medicine, just about medicine. It's about the values and relationships that we have with each other. So Dr. Don Berwick continues to challenge us to face uncomfortable truths and to imagine better possibilities. So please join me in welcoming Don. So welcome.
Thanks so much. I couldn't be happier than to be here. I've looked forward to joining your group for this session for a long time. And I hope, as I shared with you, that I could perhaps sit in more regularly and be listening instead of talking.
Yeah. You will be more than welcome to do that. So for people who are in the community, they know the format. I will ask a few questions to begin to kick the conversation, and then we'll have hopefully the vast majority of time to open for questions. So as you listen to the conversation at the beginning, start to think about what questions might pop up for you and what do you want to ask. So Don, I want to ask you about the current moment. If you had to describe the current state of American healthcare system in one word right now, what would that be and why? And now it's a tough question, but like I know you have some wisdom for us there.
Yeah, well, thanks for sending the question in advance. Didn't really help much because I'm not sure what my answer is. I think my answer is it's a mess. It's a mess. I hate being negative about it, but I'm quite worried. It's a mess on top of a mess. And so the two components of that, first is that in my opinion, the state of healthcare prior to the Trump disaster is already troublesome. And I spent my career trying to work on improvement of the capacity of healthcare systems and people to meet the needs of the people they want to help. And they're missing the mark. It's much too expensive, a lot of waste, which denies opportunities to other investments. It's sort of off target because it's quite good at acute care, but it doesn't deal well with chronic illness or with prevention and causes. It doesn't deal well with human error. We all constantly make errors. That's part of being a human, but the system is prone to damage done when we just are humans. And it's highly inequitable. It's a manifestation of the overall level of injustice in the country. It's also in its financing right now, regressive financing. It's probably the biggest subsidy to the rich in our country, taking stuff away from poor. And if you go to the global scene, it's really not meeting needs. That was all true before Trump ever appeared on the political scene. He and his cronies have made it tons worse, murderously worse. And so there are now manifestations in healthcare that are even more harmful than the status quo system. The reason I hesitated with my answer, though, is there's a kind of magical thing that goes on in healthcare that I don't quite understand, which is despite the systemic mess, we have a workforce that case by case tries really hard and in fact does remarkably well, saves lives, does superb care of very, very sick people. So somehow within this terrain of disarray and waste, wonderful things happen every day. And that's kind of paradox.
Yeah, and it's so interesting, Don. When I hear you speak about that, you're absolutely right. There's that contrast, like many of our colleagues, like who are doing the everyday work in such an amazing way with so much commitment. It raises the question, like, we're still spending a lot, So if this was not costing Americans a lot, like then you would say, like, well, it's inequitable, it's a mess, but at least it doesn't cost us a lot of money. But in this case, like it's not the case. It costs, I think, the most in the world, and that has been puzzling. Like, how do you reconcile that? How do you reconcile that there's no reaction from the people? And I don't know if you have any thoughts about it. Like that people are not saying like this cannot be right, even if we are rich, like, like that it costs us the most for around the world.
Well, two things. One is I think that most clinicians they're good. They're trying hard to do well, and most
Yeah,
patients are grateful. And so there's an underlying culture of people want to be supportive of their clinicians and the clinical system that's helping them. There's a kind of gratitude works. And so when you become critical, people say, well, it's not very nice, or
yeah,
I don't want to criticize my doctor. At the systemic level, it's all about money. We are a money machine in healthcare, and lots of people get very wealthy. In the United States, wealth creates power, and the power preserves wealth. And so it's a lot about the money. So
yeah.
when you try to push back and make changes, you're starting with less formal power than would make change easy.
Yeah, and we're gonna talk about it. I think it's really interesting how that plays out. And going back to that relationship, because you're saying like maybe there is no kind of like larger movement to push for that reform on the side of the patients, because there's a lot of trust and respect and love for clinicians that they are connected with. But on the other side, going back to the systemic problems, there's definitely, we are seeing more people, more doctors, more nurses leaving the profession. And just to make it really contemporary, like I was reading the news last week, and kind of like the visa policies. Like I was, a recipient of a visa a long time ago, and I know this whole kind of like journey from kind of like, oh, you're coming into a country and you're unsecure and whatnot, and what's happening. But this H-1B thing, like draconian visa fees, I don't think it's going to help like get more doctors to United States, which we desperately need. So what do are we shooting ourselves in the foot when we are keeping the doctors out that we need, or like
Oh,
what's the story there?
absolutely, yes. Well, first, let me emphasize it's not just doctors. There's a whole healthcare workforce in jeopardy. Our nursing shortage is massive globally and in the U.S. Plus, all the people, the very low paid workers, home healthcare workers, and people who work in nursing homes, all force of human talent is being squandered or impeded now by these stupid policies. So yeah, we're shooting ourselves in the foot. It seems to be an enterprise now in the Trump administration. My wife is in the field of sustainable energy, and she every morning over breakfast we talk about how we're handing the future of energy over to China. We're just resigning. We're leaving the field. It's so stupid.
Hmm.
In terms of the doctor shortage, yeah, it's a doctor, nurse, and workforce shortage, and it's
Hmm.
bad now. It's going to be worse. Uh,
Yeah.
unless
And do you think like you were administrator of CMS, so you could have like this insight in a bigger picture? Who is going to be the most affected, like in terms of kind of like the communities that are going to be the most affected by
I
that?
mean, it's always the poor in our country, blacks and people of color, and then poorer communities. They always bear the brunt. It'll be rural and safety net system hospitals they're going to really struggle. And sooner or later, the rich will find their way to a doctor, but people without resources will have trouble
Yeah.
doing that, and we'll end up with a system even more tiered than it is now. Children, the recent report for the Make America Healthy Again report entirely misses the mark as to what is hurting American children. The status of American kids is actually quite poor. There was a remarkable article in JAMA, I think, just a couple weeks ago from uh, Penn and UCLA or UCSF.
Mhm.
It's a summary of the status of American kids, and it's at the bottom of OECD countries. We're the worst.
Well,
So child health status and talent development of any OECD country. So if you really want to make America healthy for kids, your policies would be completely different from what this administration is pursuing.
yeah. Speaking of Make America Healthy Again, RK Jr., as we know, has become the face of that movement in many ways. And what I would say, like from my perspective, like he's sowing mistrust in public health, like, and he has been doing that for quite a long time. But now, how do you think, like, how dangerous is this wave of mistrust? Like, what is the, it's kind of on a front face, we can see it like, like this is going to be, but I'm really curious about the long-term effect of that and the effect on the faith in science and all of that. Like, what are your thoughts? How long it will take to recover from something like this, actually?
The immediate playing field of vaccines is quite dangerous. I mean, we're giving up benefits from science that's very well established about preventing illnesses that are immunizable. And I don't know what his problem is, but you throw away the science, people are going to get hurt. The disinvestment in science, the reduction in cuts in NIH and CDC will be very, very hard to recover from. It'll take a decade or two to build back because people are ending their careers. They're leaving the field, and science development is all about um, uh, it's all about people. It's about people being allowed to search for the truth. So I think we're going to pay a price. I think these people, the administration, they're smart enough to do things where there's slight delay in effect. For example, the Medicaid cuts that are going to and coverage cuts, rescissions, and supports to buying health insurance probably will take insurance away from about 15, 16, 18 million people in the country, almost completely reversing the gains of the Affordable Care Act, but that not until 2030. And so we'll be well beyond the midterms, and Trump will be history, I hope, by then. But that's when things will hit. In the
Mm,
shorter run, I think our risky behaviors in public health, defunding public health, we're just sitting on the edge of a precipice. If there should be another outbreak or pandemic, we will be much, much less prepared
yeah.
to deal with it. So these are very dangerous policies, and mistrust in the public leads people. I mean, people get confused. They don't know what to do. They don't know who to trust. And so they stop doing things that are good for them. So that's going to be hard. All of that, I just have to add, for all of the first world problems that we have because of this murderous regime, what's happening in the global south is tons worse. I was at a meeting of ministers of health in Latin America and the Caribbean last week in Medellin, Colombia, and had lunch with the Minister of Health of Haiti. And oh my goodness, just describing the size of the rug that's being pulled out from under that troubled country with the cessation of American support, including, of course, PEPFAR and HIV care. It's 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 just enraging.
Yeah, no, I could totally see that. And in our conversations in a community with people outside of US, like that, those effects are real, and it's happening quite a bit. I wanna stay a little bit on this topic of mistrust and how is it kind of like created. What do you think the response, institutional response from those institutions who are still interested in maintaining that should be? Because on one side, like I was trying to sense make like what is their strategy actually? Like aside from let's dismantle the system as it is, let's destroy something. What is the actual strategy? There's a theory of kind of like this is strategy it's a power grab. You're trying to gain more resources. But what about the institutional response from public health institutions that are still interested in maintaining that relationship? What should they do in this environment, in your opinion?
Well, it's easy to preach. I think the circumstances are very risky and fraught for the people that want to keep with doing the right things. And so I don't want to sound self-righteous or simplistic, but I have a lot of favorite quotes, but one of them, I think it's C.S. Lewis. I'm not sure. It's that courage is not just one of the virtues. It's the form of all virtues at the testing point. And we are testing courage now as organizations have to do things. If they are going to fight this, are going to have to speak up and in some cases suffer the consequences, withdrawal of federal support, targeting with illegal maneuvers by the Trump administration. So it's easy to preach and say, speak up, but that's the right answer. I think it's got to be voiced despite risk. I would love to have a conversation about the reality of that. So let's say you're the CEO of a hospital that's seeing your ability to help vulnerable populations do better be eroded, or you're the president of a university that's now being
Yeah.
to cease visible activities on equity. What do you do? I think the right answer is you speak up, you fight, and you fight back, despite what will happen to you. But what does that mean? It means then you will have more grants terminated, you'll be in more lawsuits. What do we really need to expect of leaders? I've come down pretty firm on that it's a time to stand up. Now, what we're seeing out there is a
A
bimodal
mix.
response. Yes, there are some that are stepping up and saying, no, you just can't do that to me and my mission and the people that we're trying to help. And then they're speaking up and they're taking hits because of it. And others are saying, well, let's try to just get through this. I was with a meeting yesterday of a number of colleagues dealing with patient safety. It's a very big
Mhm.
interest of mine. And a question had arisen in the Veterans Health Administration. Someone who studies the VA very closely is noticing the amount of pressure the VA is under. The comments from the cabinet level administration members are attacking the VA as wasteful and stupid and incompetent. Completely wrong. The VA is a wonderful system with all the troubles of big systems, but it's really,
Yeah.
really important, really terrific. And they've got a track record on patient safety that is extraordinary. So a friend of mine called me and said, isn't it true that when you put a workforce under pressure with these criticisms and cutbacks and constraints, that patients are at risk? That creates risk. And the answer is absolutely yes. We have firm scientific data on that. And the question was, would we, a group of patient safety scholars, be willing to write an op-ed on patient injury as a result of the way the VA is being dealt with?
Mm.
And to my surprise, the majority members of the group said, no, no, we need to stay quiet. We can't make trouble now. That'll come back and haunt the VA. The administration will put a target on their back.
Yeah.
Goodness.
Yeah, it's such an interesting moment, and you're right. Like like we started the courageous clinicians community before this whole started to happen, and now it's kind of like more relevant. The question of courage as becoming more relevant on every day. But I also want to. I always felt that there's an opportunity as well to go directly to the communities to actually
Yes.
renew and rebuild the relationship that maybe was lost in some of the kind of like everyday work and things like I was thinking about the institutions like universities. Research has been a little detached from people, and therefore people are not willing to fight for it because they have no tangible connection to it. So maybe alongside with standing up, we need to also build connections and build these relationships or rebuild them in a much stronger way.
Totally with you 100%, Pedja, as you know, because you've been talking with Cliff Gauss and Rick Cathillan and me and others. You must be right. In fact, I would have learned this from you. I mean, you were kind in your introduction, but you to me are one of my real heroes in thinking about that challenge, and you've lived it before you came to the U.S. So it's a question, not a certainty. But what do we know? We know that the policies that are playing out now are hurting people and will hurt many more. We know that there's mistrust and misunderstanding in the public. We also know from surveys that the public isn't too happy with what's healthcare is happening right now. The Gallup poll done maybe now already 6 months ago was very firm. The public is, on average, very upset about cost. It's out of pocket. This is money that is draining from their wallets and their bank accounts. Plus 110 million Americans are in medical debt, and it's the largest cause of bankruptcy. So they're worried about cost. They're worried about access. As you said, with the workforce challenges now, people are having more and more trouble
Accessing.
finding a doctor. Or I need a specialty visit for some problem I'm dealing with, and the first available appointment's February 4th. And I have to live with that. The public's pretty upset about what's happening to access. And then third is they're aware of complexity. They know that the healthcare system, which should be simple, I love the principles you showed, but one of them is simplicity and not healthcare. Public's upset. So we have lots of data on the seething kind of undercurrent of, I don't like this in the public. How could that become political force?
Yeah.
Blunted now because the moneyed interests don't want change. They really don't. And uh, I think that if we had a way to take this public voice and make it action, what was the first principle? I can't remember the wording you used, but it's not just
People over posture.
posture. We've
Yeah.
got plenty of posture, but the people.
Yeah.
The other thing that's interesting to me in this, sorry to carry on, but I'll stop in a minute, is the economic interests of corporations in America. Remember, they pay 50% of the cost of healthcare because we have employer-based insurance, and they have been remarkably passive. For 4 decades, they've been passive. They've never said, wait a minute, we want to be able to pay our employees more to compete in a global marketplace, to pay our shareholders, whatever you want to say. And healthcare is taking all that away from us. They don't do that, but it's true. And so I wonder if there's a kind of peculiar intersection of potential action here between the employer community and just people out there who aren't getting a fair shake.
Yeah. No, look, I think that's right. And I really do feel like that question, and we can explore it with the participants here as well. Like, what it will take to build that movement alongside clinicians and patients where they exist and start doing stuff. I think that the possibility for first action, and I wanted to hear your thoughts because I've heard you speak about that, is a medical debt that is a like a chronic illness on its own. It's making people sick in a way. So what would it take care, like what do you think will take that to cure that problem, not to cure all the problems, but to start there, to think about like, okay, how can we end up the toxic medical debt that is harming so many families and so many patients around the country, and doing things in the name of clinicians, if you want to put it that way, like somebody is actually going after these families, um, and like it's in the name of clinicians who are serving them so tirelessly, in many ways.
I think you're right on, and I take it from your book and Marshall's about how to get started and finding the thing, a thing, where you can name it and say, this is what we're going to tackle. Medical debt is a soft underbelly. It's possible there. Just to go over the data again, it's about 1 in 3 American families are in medical debt, and it's the largest cost of bankruptcy in the country, or second largest, I think. It's unnecessary. It also is kind of, there's a illogic behind it because the medical debt for hospitals is they're not going to recover most of that money, and so it's fake money. And I believe that it's possible to have policies at the institutional level which simply write it off. And there are a number of nonprofit organizations that have been set up to buy medical debt for pennies on the dollar from hospitals. The answer, in other words, the real answer is it can be eliminated. It
Yeah.
can be eliminated, especially for people for whom it's a special burden. So I think that'd be a great move to make. And I think it would be responsive to people. And I think we could get the logic would favor action. The more general question for me is the generalization of that point, which is what are the itches that need to be scratched? What are the things that are really bugging people? The other thing that is pretty clear is pre-authorization behaviors, in which insurance companies, they put up barriers to authorizing needed procedures through all forms of review. And that occurs also in the federal structure through Medicare Advantage behaviors. In the Medicare market, recently, the Trump administration has proposed an expansion of pre-authorization processes into traditional Medicare, which is it's like an infection spreading, and I think it's possible to get the public exercised about that.
I know we had few hands raised, but we only have 3 minutes, and I actually wanted to ask you that question, Don, for a final one, because it's one thing to recognize, as we know in movement building, what is the problem and what are the grievances. The other part of that equation is the vision.
Yes.
And that vision is usually the only thing that can move people on a much bigger scale than anything else. So in the last 3 minutes that we have, can you paint that vision for us? Like, what would be, from your perspective, from your experience, from the wisdom that you have, what would be the vision that in this moment, realistically and hopefully we can aspire to?
Well, we're all connected, and I think that the instincts of children and the instincts we generally arrive at with in our daily work are instincts of compassion. I think they're very, very deep. People want to feel and act on compassion and be so treated. We can have a healthcare system that acts with that as its first principle, that kindness and compassion are the beginning of everything. Right now, the money and the politics and the legacy structures and the stresses are covering all that up. But how would you like a system which begins with kindness and always uses that as its compass? That's what we really can have. We have amazing technologies now. I mean, the ability to bring technology to bear to relieve human suffering is so impressive. But we have to begin with a sense of connectedness and caring for each other. If that's naive, then I'm dead. I'm done. I'm lost. If that can't work, I don't know what can. But that's where I want to start. Every people want to help and be helped, and we could have a healthcare system that does that.
I love that. Starting with compassion as a principle, or empathy first, as we pointed out in
Empathy
this
first,
community.
yeah.
So let's give a big round of applause for an amazing conversation. And Don, thank you so much for
Thanks for all.
joining us today and having this conversation.